Dr. Naji. I'm a radiology consultant and I'm leading the service for intervention radiology in Norfolk Park Hospital. We have here a fully integrated digital fluoroscopy machine in the room there, and we have here like a 5-bed day case service. The team comprises other 5 intervention radiologists, and we are in the process of appointing a 6th person. We also have 7 full-time radiology nurses, and we have also enough radiographers to support the service.
The on-call service? The
on-call service, yeah. We have 24/7 on-call service for vascular and non-vascular intervention procedures.
So I'm here, I'm asking you questions on behalf of the inspectorate who are coming round. One of the questions specifically is about tunneled central venous catheters. How many do you get placed in this unit here?
Roughly in a week we would probably put between 6 to 8 lines, split it between feeding lines for St. Mark's and tunneled Hickman lines for IV access for other units.
Okay, and does this, that's quite a large number, does that have an impact on the service?
We are coping. I think we're fine. We can accommodate this, and we are looking in the process of, as I say, appointing a 6th, and that will probably will allow us to fit them slightly quicker than we normally do. We now put them within 1 to 2 days in most of the time. On the other hand, if clinicians come and tell us that this is an urgent one, the patient needs feeding very soon, then we try to fit them in the same day, and we have the capacity to do this. But on the other hand, sometimes it takes a bit longer than 2 to 3 days if we have emergency cases coming from other departments.
Indeed. Okay. And other questions relating to the management of complications. So central venous stenosis, for example. How do you manage that in this unit?
Once we have any clinical concern from the clinicians that there is something, we get the patient straight away and we do venograms, either with duplex or CT or conventional venogram, and we aggressively treat them with balloon angioplasty and sometimes stenting if needed.
Okay, and does that happen often?
Not very common with the recently positioned line, but with patients who had the lines for a long time, it's a relatively common scenario, yes.
To a reasonable amount?
Yeah.
Also central venous thrombosis?
Yeah, again with central venous thrombosis we are very aggressively attacking and tackling this problem. Once we get the clinician concern, we try to do them in the same day or in the next working day. We get the patient for venogram thrombolysis, and once we see underlying problem, then we tackle it with venoplasty and stenting as well.
And the occasional patient who's lost all central venous access, what do you do in that situation?
Yeah, we also recently we've done few cases where we did the chronic venous recanalization. We had cases that the whole iliac veins and the inferior vena cava were completely blocked and the patient had no other option. We went in and recanalized all the veins, and we put stents and used these to put lines in. Sometimes if that option is not feasible for one reason or another, then we have the other option of going from the skin through the liver and getting the line into the IVC and maintaining what we call a percutaneous transhepatic feeding line access.
Excellent. And just in terms of the cover, just to reiterate, there is enough cover for when the service isn't just dependent upon yourself.
No, I'm just leading the service. I'm doing the interview because I'm leading, but I'm the link between radiology and St. Mark's. All the other radiologists are capable of doing what we do, and the service is maintained by all of us.